Hi everyone, I'm really pleased to present today some of the methodological issues we faced in our iKASCADE project. So this is a partnered project among 6 countries that brings together experts in prescribing cascades in older adults, and the focus of our work is to look at sex and gender, the role of sex and gender in the development of prescribing cascades. So we have a team comprised of Israel, Ireland, Belgium, the US, Italy, and Canada. So really briefly, what is a prescribing cascade? It occurs when an adverse drug event is misinterpreted as a new medical condition, and then the patient goes on to be prescribed another subsequent and potentially unnecessary medication to treat that side effect. And some of the key methodological challenges we faced is really how to explore gender, not so much sex, across the partner countries that have diverse populations, diverse health systems, and really different data sets. So maybe first I'll tell you a little bit how some of the data that we've been using, and then we'll go into the challenges. So we're looking at sort of 3 different approaches and bringing them together, the pieces together, to further our understanding of how gender impacts prescribing. So in the bottom left corner, you'll see we're constructing country portraits. And so that's looking at gender norms, gender relations, and how they're enacted and in the different health systems across our different partnered countries. We're also in the top right, you can see a bunch of circles. Those represent clinical and health administrative databases that we're using to look at differences in the frequency of prescribing cascades by sex and country. And then we're also doing qualitative interviews with physicians using clinical vignettes in male and female patients to look at whether there is implicit gender bias in physician prescribing practices. So to go back up, some of the key challenges we've had is around a lack of frameworks to implement sex and gender into the cross-national comparisons of health systems. We've also, we've heard a lot of discussion this morning about the challenges of measuring gender in quantitative databases, and certainly in the existing data we're using, we have measures of sex, so male, female, but there's some challenges around gender identity and measuring that. And then, of course, looking at the intersection of sex and various sociocultural variables is a little bit complex because how these variables are measured and which ones differ across the countries. And then with respect to the clinical vignette study, we varied the vignette only by the sex of the patient, just more for feasibility reasons. And so it's made it a bit more challenging to look at the intersecting factors and how those may relate to and contribute to gender bias. So one of the ways that we've overcome the lack of existing frameworks to look at building these country portraits is creating our own. So we've adapted an existing gender framework that looks at health systems, and we've created a standardized step-by-step process to look at and build country portraits using standardized databases and reports, and also our site-specific data. And for the clinical vignette study, as I mentioned, what we're doing is among male and female physicians, we're randomizing them to receive either a male or a female patient vignette. And so, if we added on different dimensions, like if we also wanted to consider if the sex and the income of the patient contributes to some of this gender bias, then you can imagine we would need to have then potentially 4 different vignettes, which leads to increases in sample sizes of physicians we would need to interview. And so to overcome this challenge, what we've done is we've asked a series of explicit questions at the end of the interview to ask about how treatment decisions would vary if the patient was, for example, a caregiver or had a different occupation. So pleased to talk about that more in our breakout, and thank you to our funders and our team.